Hi, I'm going to talk about etiology and epidemiology of hepatic cirrhosis. So, here in this slide, I'm going to talk about etiology first. So, what is hepatic cirrhosis? So, hepatic cirrhosis is basically a scarring of liver tissue which lead to a liver failure. This problem can be caused by both congenital and acquired factor. So, what is acquired factor first? Acquired factors are those factors which a person acquired during his lifetime. Like it can be caused because of alcohol abuse, because of viral hepatitis, and because of non-alcoholic fatty liver disease, autoimmune hepatitis, biliary obstruction, drug toxins. So these factors can be acquired by a person during his lifetime, which can lead to this cirrhosis problem. Other factor, which is congenital factor, that can lead to this disease, but it's very less common in the people. It could be like because of genetic disorder, which is very less common. So this disease which causes this cirrhosis problem could be Wilson disease, because it happen because of the mutation in the ATP7B gene that causes copper accumulation or hemochromatosis, which is happen because of HFE gene that causes iron overload, which can lead to the scarring over the liver tissue. In summary, cirrhosis can be caused by a number of factors like we have discussed: alcohol abuse, viral infection, metabolic disorder, autoimmune, and etc. etc. So here in the next slides, we're going to talk about the etiology of cirrhosis from 1993 to 2021. So there is this study been conducted which show us like what are the reason of hepatic cirrhosis in the specific countries. So as we can see in the Eastern Europe, the reason for hepatic cirrhosis is alcohol, similar like South America and in India as well. And in the Eastern Asia, the reason is hepatitis B, and in North America, the reason is hepatitis C virus. So this gives us the etiology of the disease over the globe. Now we're going to talk about the epidemiology of hepatic cirrhosis. Cirrhosis is a significant contributor to the morbidity and mortality in the patient. With this chronic liver disease, persons suffer from hepatocellular carcinoma, liver failure, hepatic encephalopathy, and visceral bleeding. So the factor that causes hepatic cirrhosis are hepatitis B, hepatitis C, alcohol liver disease, and NAFLD. But the etiology of liver disease has been changing rapidly in the recent years. The large systematic review and meta-analysis of 520 studies conducted between 1993 to 2021, which evaluate the prevalences of hepatitis B and hepatitis C infection, which causes this hepatic cirrhosis. So, there are 42% over the globe which has hepatitis B infection, which lead to the hepatic cirrhosis, while left 21% can have or have hepatitis C infection, which causes them hepatic cirrhosis. So this data give us the brief idea that in the Western Pacific region, the hepatitis B causes the hepatic cirrhosis, while in the Eastern Mediterranean region, hepatitis C infection causes the hepatic cirrhosis. But this is not all about. In the some left region, alcohol consumption and NAFLD region are the reason for hepatic cirrhosis. So the main cause of the cirrhosis vary from region to region and person to person.
So first, we'll look at the pathology and pathophysiology of hepatic cirrhosis caused by the hepatitis C virus. Inflammation occurs as a natural defense mechanism against any infection. Acute HCV infections would be cleared off by the body, but chronic infections do not. In chronic infections, repeated activation of immune cells such as Kupffer cells, which are macrophages of the liver, and hepatocytes engage in the pro-inflammatory cytokine production, while also causing more immune cells to be recruited. This increases in pro-inflammatory cytokines and chemokines, and these lead to injury and scarring, also known as fibrosis. Now that we understand the basic pathology, let's look at the cellular developments within the cells of the liver. Hepatitis C virus exposure to macrophages forms inflammasomes, which are multi-protein cytoplasmic complexes that sense viral pathogen-associated molecular patterns, also known as PAMPs. Activation of hepatic stellate cells, HSCs, lead to secretion and deposition of extracellular matrix, causing fibrosis, also known as scarring. In hepatitis C virus infected hepatocytes, a profibrogenic cytokine known as TGF beta 1 or transforming growth factor beta 1 is upregulated, which contributes to increases in reactive oxygen species and thereby increases injury and fibrosis. Now in this image, we can see anatomical changes in the liver, which is what we will be talking about now. Anatomical changes include changes in surface texture due to the formation of nodules due to inflammation. Extensive fibrosis is called cirrhosis. Scar tissue connects portal tracts, which are hepatic artery, portal vein, and bile duct and the central veins. Intercellular communication in hepatic sinusoids are carried by fenestrated or literally windowed endothelia. This endothelia lies on a sheet of permeable connective tissue that facilitates communication. Hepatic stellate cells and mononuclear cells are also present here. The sinusoidal endothelial cells and hepatocytes are not connected directly. There is a space between them, which is a narrow gap, and this space is called the space of BSA. In the case of hepatitis, however, there is scar formation in this space. This is called sinusoidal capillarization. This is a result of the fibrosis and, as a consequence, leads to the loss of endothelial fenestrations. This leads to increased resistance within the liver, resulting in portal hypertension, which in turn increases arterial flow. The liver's parenchyma responds by producing more hepatocytes. These hepatocytes form regenerative nodules, which are the hallmark of cirrhosis. Now that we have looked at the anatomical and physiological changes, let's look at the screening and diagnosis of the disease. Hepatitis C virus PCR testing confirms the viral nature of hepatitis and cirrhosis. Yes, seropositivity is a good starting point, but methods like transient elastography, which measures the stiffness or rather the elasticity of the liver, is better equipped than serum biomarkers to test for cirrhosis itself. Imaging techniques such as ultrasonography is affordable, non-invasive, detects nodules, and is useful for hepatic cell carcinoma screening, or HCC, which stands for liver cancer, and assess vein patency or obstruction. CT and MRI with contrast are also helpful in detecting liver cancer and vascular lesions, although MRI is superior. These can assess iron or fat deposition and even biliary obstruction. Apart from imaging techniques, there are other tests such as colloid liver spleen scan, which uses sulfur colloid uptake as a measure. It measures sulfur colloid uptake in the bone marrow and spleen compared to the liver, and if there is more in the bone marrow and spleen, this indicates cirrhosis. Esophagogastroduodenoscopy detects varices in the esophagus or stomach, suggesting portal hypertension. Liver biopsies can detect grade, which is calculating the extent of inflammation, and stage, which calculates the extent of fibrosis, cirrhosis. Thank you for listening so far. Now let's listen to Abdullah for the clinical management, the presentation, and the impact on the patient for this disease.
For the clinical management of hepatitis C, I will discuss about first of all goals of treatment. The primary goal of clinical management for hepatitis C is to slow down disease progression, manage complications, and improve quality of life. And this will include acknowledging the very main cause like the viral hepatitis or alcohol abuse, managing symptoms, preventing complications like ascites, vesical bleeding, and hepatic encephalopathy, and monitoring for liver cancer development. And the second one is eradication of infection. If infection is present, particularly in cases of alcoholic cirrhosis or cirrhosis due to chronic viral hepatitis, treatment focuses on eradicating the infection, and so they will include the antiviral medication for hepatitis C, antibiotics for bacterial infections, and lifestyle modifications such as alcoholic cessations. Third one is the symptom management. Symptomatic relief is indeed very important for patients with hepatitis C. Management do include diuretics, it's called diuretics for acids, beta blockers for portal hypertension, and variceal bleeding prevention. Lactulose or rifaximin for hepatic encephalopathy and dietary modification to manage malnutrition. And the fourth one is liver transplantation. In advanced cases where liver function is severely compromised and complications cannot be managed effectively, so liver transplantation may be considered. So this will give the potential for a cure and improved survival outcomes. The impact on patient of hepatitis C includes fatigue and weakness. Patients often experience fatigue and weakness due to decreased liver function and metabolic disturbances associated with cirrhosis, as this will limit their ability to engage in daily activities and work. And the other one is ascites and edema. Accumulation of fluid in the abdomen may cause ascites, and peripheral edema can lead to discomfort, difficulty in movement, and reduced mobility. Patients will find it challenging to perform tasks that need the physical exertion. And the other one is cognitive impairment. Hepatic encephalopathy can cause cognitive impairment, confusion, and poor concentration, impacting the patient's ability to work, drive, or perform tasks that require mental focus and clarity. And the last one is psychosocial impact. Hepatic cirrhosis and its complications can have a profound psychosocial impact on patients, leading to anxiety, depression, and social isolation. The presentation of hepatitis C, I will talk about subjective assessment. So, patients report the symptoms, for example, fatigue, abdominal discomfort, jaundice, easy bruising, and changes in mental status. And they will also give the history of risk factors, just like the alcohol abuse, viral hepatitis, or other liver disease. For the objective assessment, physical examination shows the sign like the jaundice, hepatomegaly, and ascites, peripheral edema, spider angiomas, palmar erythema, and asteresis. Laboratory tests also do show abnormalities in liver function tests and complete blood count and serum electrolytes. And imaging studies includes abdominal ultrasound, CT scan, or MIR performed to assess liver morphology, identify ascites or hepatic nodules, and evaluate portal hypertension. And for liver biopsy, a liver biopsy is necessary in some circumstances to confirm the diagnosis, evaluate the degree of liver damage, and inform therapy choices. And assessment for ASIDs include physical examination findings just like the shifting dullness and fluid wave, and diagnostic tests like ultrasounds. And assessment involves evaluation of mental status using tools like the Glasgow Coma Scale and some subjective complaints of confusion and forgetfulness and impaired cognitive function on examination.